Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of experts. For many, back and neck pain are common. And in this webinar, our panel of neuroscience spine specialists will discuss managing back and neck pain, cover a number of back and spine conditions, and also talk about the pros and cons of spine treatments, including when to consider spinal surgery. We will also discuss new technologies, recent medical advances, and research breakthroughs. Tonight's spine specialists will get into the importance of a multidisciplinary team approach to your health. Our spine teams work together with our patients to treat, prevent, and find cures for all kinds of spine disorders using an array of surgical procedures, including minimally invasive surgery and robotic spine surgery. Well, thank you so much for submitting your questions in advance of tonight's discussion. The questions that you will hear me asking the panelists tonight are all submitted right from when you registered for this webinar. If you have any additional questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you'll see an icon that says Q&A. Well, we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Finally, don't worry, we have taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I would like to introduce our experts for the evening, starting with Dr. Christian Holscher, neurosurgery, spine surgery, Dr. Ahilan Siva, neurosurgery and spine surgery, Dr. Anthony Stefanelli, neurosurgery and spine surgery, and finally, Dr. Jonas Gopez, neurosurgery and spine surgery. So with that, I think it's time to just go ahead and dive right into the questions. I know we have a great discussion ahead of us. So I will start with Dr. Holscher, if you're ready. So question number one to start us with this evening, can you talk about what a team approach looks like when working on cases and what specialists are on a treatment team? Also, feel free to go ahead and introduce yourself.
Thank you, first of all, Sarah, for having me. Always great. I enjoyed I did a similar webinar with kind of, community outreach probably about 6 months ago. Really enjoyed it. Same topic, spine. It's a nice venue for people to be able to have kind of a more casual approach to just kind of, maybe, ask some questions that maybe, are a little bit harder to ask in kind of the confines of a short clinic visit. So really happy to be here. Thank you for having me. And so to get to that first question, and can everyone hear me? Am I coming through okay?
Yep, you sound great.
A team approach, it's an interesting question. So a team approach, I think means a couple of different things. Like oftentimes a team approach is more kind of the stuff that happens before you get to surgery, if it's going to get to that point. Like in the operating room, it's generally, at that point, the care team is anesthesia, it's the surgeon, it's the assistant for the surgeon. But I think a lot of the team approach to stuff happens, before you ever get there. And I think about it kind of in the ways of, trying to avoid surgery and diagnostics, right? So diagnostics means like really pinning down, is this a spine problem or not, right? Spine problems sometimes are obvious. Sometimes there's a big, obvious disc herniation with obvious nerve or spinal cord compression. And the problem is, kind of existing, without much else going on. But most of the times, pain and symptoms that patients are having are existing kind of in this background of other stuff that's going on, right? It's bad hips, it's bad knees, it's stuff like rheumatoid arthritis and kind of generalized diffuse arthritic change in the spine, unlike kind of the young patient with pristine MRI, except for a single level soft disc herniation where the answer is pretty obvious, right? And so the diagnostics are like, well, sending people to neurologists or rehab doctors to consider getting an EMG and a nerve conduction study. Is that pain really, is there evidence that pain is coming from nerve root irritation? Or maybe the EMG is negative and we need to be getting a hip injection or an knee injection, right? So to that end, maybe sending someone to an orthopedic surgeon before surgery and saying, let's just rule out some hip or knee stuff. Can you do a prednisone shot, a cortisone shot into the hip or the knee and make sure that's not the issue, or the sacroiliac joint or something that is not necessarily, the spine. I would also add that, trying to avoid surgery is a multidisciplinary approach as well. It always starts with physical therapy. It starts with a pain management consultation, right? Doing epidural injections, facet injections, a whole gamut of non-operative stuff that I think we'll talk, a little bit more about in a little bit. That's probably more the team approach to surgery. It's one, do we think that the spine is definitely the problem here? And two, if it is the problem, is there any way that we can tackle this without needing a scalpel, right? And sometimes the answer is no, but I think once we get to the point where we commit to surgery, the team approach is very, very focused on it's anesthesia, it's surgeon. I may have another surgeon with me if it's a complicated case, but it's really now we're kind of hyper-focused on the spine surgery part of it. And the team approach is very important, but I think a lot of that is focused on kind of the preoperative care as opposed to like in the actual operating room.
Okay. Well, thank you so much. Really interesting to hear that team approach, even stemming from non-surgery options. So we appreciate it. Okay, we will go ahead to question number 2. Dr. Siva, this one's for you. Relating to earlier point, what are some non-surgical treatment options for back and spine issues?
Yeah, it's a great question. Thanks again for having me, and it's a wonderful venue. Really piggybacking off of what Dr. Holscher said, I think I can speak for all of us, here at Jefferson, neurosurgery, neurospine, and that we really feel that spine surgery should be sort of a salvage option. It should be an option of last resort. And what that means is that even if you're coming to see us in the office or in clinic, sometimes the most valuable thing that we can do is help patients navigate the non-surgical options that may be able to get patients back to doing the things that they love and get back to work, whatever the case may be. So to dive into that a little bit, the obvious one that people may think of initially is physical therapy. What I would add to that, though, is that not all physical therapists are created equal in the same way that we feel like not all surgeons are the same, and some surgeons have different philosophies than others. So I see many patients who may have tried physical therapy in the past, may not have had a great experience, for example, maybe it made their pain worse, and they kind of then naturally dismiss that as something that may never, ever be helpful for them again. And so part of what we can do as surgeons is help really hone in on the specific exercises, specific muscle groups, specific activities that we want to help strengthen for that patient, and then recommend physical therapists or physical therapy offices that are very good at those kinds of things, and be very explicit in the kind of recommendations we make instead of sort of a blanket sort of one size fits all, hey, go to PT, I think that's going to help you. So I think that's one thing that hopefully will be useful for patients who may have tried physical therapy in the past and aren't sure if it's an option in the future. The other thing that Dr. Holscher mentioned, of course, is epidural steroid injections. This is a great option, one, to help identify where the actual pain generator may be coming from and confirm what our theories are. And secondly, in some patients can give you really meaningful relief for multiple months and is a way to avoid, a much more bigger surgery or operation. And then beyond those two things, honestly, things like yoga, meditation, things like that we traditionally maybe 10, 15, 20 years ago weren't recommending, we're now seeing with real data, can have an incredible impact. So, we're surgeons, that's what we do best. But I think we also can serve a role in helping patients navigate this maze and figure out what non-surgical options exist.
Absolutely. And really interesting to hear that last point about yoga and even meditation as a potential option there. But a follow-up question for you, is there a certain point in treatment when maybe you would go ahead and recommend surgery instead of some of these non-surgery options?
Sure. Yeah, great question. Thanks for that question. There are certain so-called red flag signs that we speak of often that would warrant sort of urgent consideration of surgery. So these are things like bowel or bladder dysfunction, incontinence, new weakness, for if it's a lumbar spine, for example, a foot drop or something of that nature, or if it's a problem in the neck, issues with balance, issues with hand dexterity and weakness in the hands. falls that we think are coming from spinal cord compression. These are the kind of things that generally warrant quick surgical evaluation. Apart from those sort of red flag signs, though, in general, what I tell patients, and I'm sure everyone else here would agree, is that for the most part, spine surgery for degenerative problems is an elective issue, which means it's a quality of life question. And so the question really becomes, is this spine problem affecting your life, your day-to-day, whether it's work or spending time with your loved ones? Is it affecting your quality of life to such a degree that the ordeal and the risks and sort of the quote unquote price you pay of surgery is worth it? And so when it gets to that point, sometimes it's ready to jump off the non-surgical track and sort of consider surgical options. What I will say is that with modern advances in spine surgery, sometimes patients are candidates for these sorts of procedures earlier in their evolution of care than they might have been 15, 20 years ago when spine surgery was a lot more morbid and a lot more of an undertaking. So with minimally invasive procedures or motion-sparing procedures where we're not having to immobilize spinal segments and put in a bunch of screws and rods, we can oftentimes get patients better in a way that is very different from what spine surgery was like 20 years ago. And for patients that are candidates for those minimally invasive or motion-preserving procedures, they may be a candidate earlier on in their evolution than they might have been 20 years ago.
Okay, well, thank you so much. And again, just interesting to hear all the options out there. So we appreciate it. Okay, moving along to our next question, Dr. Stefanelli, this one's for you. A simple question here, but I'm sure a complex answer. Can damaged nerves heal?
Right. Well, again, Sarah, thank you again for having us. As Dr. Holscher and Dr. Siva said, I think these are a great platform for patients. We've all done a few of them, and hopefully they're very helpful to the folks in the community. So, like most things in life, the answer is it depends, right? The nervous system is really broken down into two main parts. So everybody's kind of familiar, we're mostly familiar with the central nervous system. So we consider that the brain and the spinal cord. And the spinal cord runs up until about the top or the bottom of the mid-back. When the spinal cord ends, it frays off into a bunch of nerves that look almost like spaghetti or a horse's tail. Actually, it's called a cauda equina, which means horse's tail. It looks just like that. The transition point between the spinal cord and those nerve rootlets, we call them, and then as they leave the spine, they become nerve roots and then go out to the peripheral nervous system, thinking things like people are familiar with carpal tunnel syndrome. That's when the nerve is compressed in the hand or in the wrist. That's a peripheral nerve. So when it comes to talking about nerves that are damaged, can they heal? It depends on where they are in that tree. And that really affects how they are either able or not able to heal. So for example, nerves in the spinal cord itself have much less of a capacity to regenerate or heal, as do nerves in the peripheral nervous system. So nerves in the hands and feet and skin. So when people have injury to their spinal cord, whether it be from a trauma, whether it be from arthritis, which we see very commonly, compression of the spinal cord, the dysfunction that we see in spinal cord compression tends to heal much less than nerves that are farther along the tract, if you will, or farther out into the body. After you leave the spinal cord and go from the central nervous system to the peripheral nervous system, the nerves that are in the arms and legs and hands and feet, they tend to heal a bit better. Now, that doesn't mean they will always heal. For example, sometimes people develop, like Dr. Siva said, a foot drop. It's a very common thing that we see both. It can happen from a compression of a nerve in the spine, in the leg, et cetera. It can happen anywhere along the tract of the nerve. The longer that nerves are damaged or compressed, generally speaking, the less likely they are, the less regenerative capabilities they have to heal. So really, to sum up the answer, it depends on where they are in the body. So central nervous system, meaning the spinal cord, tends to not heal as well. And then the second thing becomes how long has the nerve been injured? So if a nerve has been compressed for 5 years and you've had a foot drop for 5 years, even if we take pressure off that nerve, the chance of that nerve healing is much lower than if you developed a foot drop last night and came into the hospital and it was something that were amenable to surgery to take the pressure off. But even still, that foot drop after 5 years, it's not a 0% chance that it doesn't heal. So it really is to some degree patient specific, and there's no way to predict it, unfortunately, in most folks. And like I said, where it is on the tree of nerves and how long it's been damaged. So it depends.
Okay, thank you. Sounds like seeking care sooner than later is obviously an important consideration. So thanks. All right, moving along, Dr. Gopez, we will turn to you now. For someone who has spondylolisthesis of the neck and lower back, is there a best course or recommended treatment? And feel free again to introduce yourself.
Hello, everyone, and thanks, Sarah, for having me back. I also want to say thank you for the viewers for allowing us to spend part of your evening with us here. Hopefully, you'll get a lot out from tonight's discussion. But to get back to Sarah's question about spondylolisthesis, well, first of all, what is it? And the simplest definition for that is it's when one bone of the spine slips forward or potentially backwards relative to the bone below it. And we see these things on MRIs, CAT scans, or plain X-rays. In my opinion, plain X-rays, I think, show it the best. But what causes these things to happen? Well, a handful of patients are just born like that. But probably the two main causes are pars fractures, and I'll go over that in a second, or degenerative causes. So in the case of the fractures, the pars is actually a very small bone that connects the upper joint from the lower joint in the back of the spine. And because of repetitive stress or trauma, that bone can fracture. And the ones that it's likely to fracture in are in young patients who are athletes. So we tend to see those in the younger patients, but in the older patients, meaning greater than 50 or so, degenerative causes seems to be the main reason. And that's just simply when the disc and the facet joints start to wear out. In terms of the symptoms, so a lot of these patients will come to the office complaining of low back pain, stiffness in their back. They might have spasms in their thighs. They have difficulty standing, difficulty walking, and the symptoms tend to get worse as you move. If the slip is severe, you could get a pinched nerve, and with that, you'll have symptoms in the legs, such as pain, numbness, or tingling. In terms of the treatment, we talked a lot about these already, and it all starts with conservative measures, as the other doctors have already spoken. There's therapy, there's injections, anti-inflammatories, but when those fail, then you have to consider surgery. And in terms of the surgery, most are going to be decompressions with a fusion. One could try to do the surgery without a fusion, but there's always a chance that slip will progress and you may need the fusion later. But what's a fusion? Well, a fusion is when you lock one bone to the other. And the theory is that by eliminating the painful segment from moving, that will eliminate the pain. Again, it always starts with conservative treatment, but if that fails, then you have to consider surgery.
Okay, well, thank you so much. We appreciate you walking us through that. All right, we will go on to the next question, but just a quick call out. Thank you so much for everyone who have submitted their live questions already. We will be getting to those at the end of our discussion, but feel free to keep on submitting them throughout our discussion. Okay, moving along, back to you, Dr. Holscher. What are your thoughts on chiropractic manipulation and acupuncture for back and spine issues?
Yeah, it comes up a lot, and it's a good segue from a talk about spondylolisthesis and some of these common issues that we see, spine problems in the clinic. It's not even just it's much more than just chiropractic manipulation or acupuncture. I mean, there's a whole gamut of non-surgical therapy, and a lot of it is like the mainstays are always that people always get directed towards physical therapy and injections, but there's a lot more to explore. And I think most surgeons would tell you that really the minimum is PT and injections if you're trying to manage before even considering surgery. And a lot of this other stuff, is nothing that anyone is going to mandate or warrant, but I tell everyone in clinic that all these things are reasonable options. So chiropractic manipulation, for example, is always, especially for low back issues, there's almost nobody that I would say, for low back problems, can't have chiropractic manipulation. We do tend to hesitate for things higher up in the spine, if there's spinal cord compression, especially in the neck. So sometimes I'm a bit hesitant to recommend chiropractic manipulation of the neck if there's significant cervical stenosis that's leading to spinal cord compression. Like one thing that is oftentimes not recognized by patients is that the low back, which is probably the most common area where we're dealing with in clinic, there's no spinal cord in the low back. So the lumbar spine is actually all peripheral nerves. So Dr. Stefanelli had previously mentioned the difference between spinal cord and brain and peripheral nerves. And actually the spinal cord ends at about L1 or so in most people. And so most of the stuff we see in clinic is like L3, 4, L4, 5, L5, S1. And so you're pretty well below spinal cord level. And the peripheral nerves are a lot more tolerant, to arthritis and pressure. So first of all, as things relate to the low back, I'm a lot more aggressive with non-operative therapy. One, because the spinal cord is not in play there. And that includes things like chiropractic manipulation, acupuncture, always. Like anybody who's open to acupuncture, it doesn't matter what the issue is. And admittedly, it's a bit outside the bounds of what you would call traditional or typical medicine. It's certainly not something that any of us are well versed in or that we're taught in medical school. So I can't explain necessarily what's the science behind it. I have to send you out to an acupuncturist to talk about that. And but there's nobody I've ever told that acupuncture is going to hurt them. For chiropractic manipulation for the low back, it's the same thing. Again, I hesitate a little bit when there's spinal cord compression and recommending manipulative therapy with a chiropractor in the neck sometimes. Other things that are worth considering, kind of much in the vein of physical therapy, is yoga or Pilates. Like anything that is core paraspinal postural muscle strengthening is a reasonable consideration. And yoga and Pilates can be essentially considered an extension of physical therapy. Water therapy is also something that I often recommend to patients, or aqua therapy, which is essentially just physical therapy in a pool. But sometimes patients have a difficulty tolerating land-based physical therapy because it hurts, right? And so if you put yourself in a pool and kind of eliminate gravity somewhat by having your body supported in the water, oftentimes you can do many more exercises that maybe you couldn't do before, that you couldn't do in regular physical therapy. Other things like inversion tables and massage, it's all fair. And I encourage everyone to consider as much of that as they're willing to. Really, again, the bare minimum and really the mandate before you consider surgery is usually physical therapy and pain management with injections, depending on what exactly is going on. But again, all of those things are fair with very, very few, in my opinion, very few limitations.
Okay, great to know. And just as a follow-up on the mention of yoga and potential Pilates, are there any other maybe specific stretches you would even recommend for helping with chronic pain?
Yeah, I mean, it's anything. It's really just anything that is core paraspinal muscle strengthening, right? And that obviously the focus is typically on the low back or the neck when we're going to therapy, but that's what I'd say. It's anything that is just postural paraspinal muscle. The best thing that we can do to try to, we're all going to develop progressive degenerative arthritis in the joints of our spine, much like all of us will develop some degree of hip and knee arthritis. Some of us won't become symptomatic from it, just like some of us won't become symptomatic from our spine. But the best thing we can do to limit the propagation of degenerative disc disease and degenerative spinal arthritis is to have good paraspinal postural muscle strength. And many of the exercises that you see being done in yoga and Pilates or physical therapy for back and neck strengthening, like I tell people all the time, people, even really fit young patients that go to the gym and are very muscular are oftentimes not working out their postural paraspinal muscles. And so even for people that feel like they're in really good shape, they're active, you probably don't have as good of a paraspinal muscle postural core as you think you do. And that's the best thing you can do for your spine.
Okay, great to know. I think I should maybe do some planks for this.
We could all use a little yoga or Pilates.
Yeah. Okay. All right. Moving along, Dr. Siva, we will turn to you now. How is lumbar stenosis treated?
Yeah, it's a good question. So just to define lumbar stenosis first, because it's a phrase that gets thrown around a lot, and especially if patients are reading a radiology report, you might see that phrase if you're accessing your records and not exactly know what to make of it. It's really just a fancy phrase that describes narrowing around those nerves in the low back that is essentially causing pain, difficulty walking, weakness. And there's a whole spectrum of severity when it comes to lumbar stenosis, from very mild and something that may not even be noticeable to the patient to very severe, where it may be difficult to even walk a block and difficult to even stand for long, significant periods of time. So in terms of how it's treated, I'll initially refer back to sort of our general philosophy, which is that you try to get better with as conservative of a therapy as possible first. So whether that's the kind of physical therapy that Dr. Holscher is talking about, certain types of epidural steroid injections, certain types of medications. But if you've exhausted all of those types of therapies, and if it's affecting your life significantly enough, then surgery is something worth considering. Now, what you want to hope for in general, if you're being considered for surgery, is that if you can avoid a fusion at all possible, I generally try to recommend that. And so what that generally means is something called a laminectomy or discectomy, words like that, which essentially amount to a clean out procedure, where you're essentially going into the area where the nerves are getting crowded and pinched, and you're removing the structures, whether it's bone spurs or ligament or disc, that are pushing on those nerves. So if you can get away with a procedure like that and avoid a fusion, I think that's wonderful. Now, there are situations like a spondylolisthesis or a slipped vertebra that Dr. Gopez mentioned, where sometimes it's hard to avoid a fusion. But one thing I'll caution patients about is that there are a lot of surgeons out there who will see patients with lumbar stenosis and reflexively recommend a fusion, putting screws and rods into the back. And that's not always necessary. So I always tell patients that if you've been and family members of mine, if you've been recommended a fusion for a problem like lumbar stenosis, it's in your interest to get a second opinion so that you can be darn sure that there isn't a way to get better without the fusion. Sometimes that involves minimally invasive techniques through a small tube or an endoscope. And other times it's just a matter of philosophy and the surgeon saying, you know what, I can achieve the goals of this operation and get you better without putting metal in your back. And so I think that's a critical point that I would recommend to most patients, is that if you're being told you need a fusion, to really think twice, ask around, see another surgeon, and make sure that you might not be able to get better without a fusion.
Okay. Thank you. Really helpful advice there. And I like the idea of a clean out procedure. So thanks for painting that picture there. All right. Dr. Stefanelli, next question is for you. Can you talk a little bit about epidural treatments and back and neck arthritis and bulging discs?
Sure. So I think as we've sort of echoed a bit, all four of us here, pain management. So what falls under the guise of pain management. So things like epidural steroid injections, targeted nerve injections, nerve ablations. All of these modalities of treatment are generally a mainstay for us before we even consider doing surgery. Particularly when it's involving the peripheral nervous system. So meaning not spinal cord compression. Spinal cord compression is a different beast. And when people have symptomatic spinal cord compression, pain management is generally not the correct answer. It's surgery. There's really not many treatments for symptomatic spinal cord level compression beyond surgical decompression and usually a fusion, but not always. But when it comes to, as Dr. Holscher was talking about, issues in the low back, which we generally see more frequently than not, so people that have things like low back pain from lumbar stenosis, people that have what we call, or what patients generally will come in or hear referred to as sciatica. Sciatica is generally a term that people think of that lightning bolts or pain and numbness shooting down the legs. And the term that the true term for that is actually called radiculopathy. And that can happen in the arms or the legs. And all that is reflection. It's a reflection of that there's some compression of the nerves as they're leaving the spine. So each level of the spine has a nerve that comes out either above or below it. And when the nerves get pinched, either as they're leaving or right before they leave or right after they leave, we get what's called sciatica or radiculopathy. Again, can be in the arms or the legs. So pain management or injections tend to be extraordinarily effective for those types of problems. So sciatica or radiculopathy, back pain, things like that. And most of us will not even operate on patients without them having done some form of that. So if a patient comes into my office, and Dr. Holscher sort of alluded to this as well, if a patient comes into my office and has radiculopathy or sciatica, the main treatment is actually time. So most of these things will get better over time, even if we did nothing. So usually give patients 4 to 6 or 4 to 8 weeks if they have an acute sciatica or radiculopathy. Even if we didn't do anything, it will get better in most people, greater than 90% of people. But we don't like to see people suffer, so we can generally offer them. And again, we don't do them. None of us do them. The pain management physicians do them, but we send them for injections. What the injections do, it's an anti-inflammatory. It cools down some of the inflammation of the nerve that's been irritated. And the reason why we do that is because a needle in your back is oftentimes way better than having surgery. It's way less morbid. It's a simple procedure. And most patients with sciatica, radiculopathy, mild back pain, they will get better with treatments like that, with epidural steroid treatments or nerve ablations and things without ever having to go through an open, minimally invasive, even surgical procedure. So for non-cord level pain, we always recommend at least trying it because again, like we've all been saying, spine surgery, unless there's some red flag, which there rarely is, unless it's cord compression, it should oftentimes be done before considering a surgical procedure with one of us because it's just a lot better tolerated for obvious reasons. So to sum it up, just a mainstay treatment. It's something that we all recommend before having elective spine surgery. And then the other side to that is oftentimes injections can be diagnostic. So we like them to be therapeutic and that they help the patient get some relief. But there are times when we see people in clinic that have spines that look so bad and their symptoms are all over the place that we can't localize it to one level. Their entire spine looks terrible. In a lot of the body, we can give patients new liver, we can give patients a new heart, we can give patients new lungs. We unfortunately are not at the point yet and probably never will be where we can give a patient a new spine. So sometimes what injections also allow us to do are create diagnoses, meaning that let's say a patient has 5 levels in their spine that look terrible. And we want to keep surgery very minimal and address only the most symptomatic level. We could send patients for injections, targeted injections that will tell us, like, let's say they get 3 injections over a period of time at the different levels, and only one of them made them feel better. Well, that helps guide us from a surgical standpoint to say, okay, well, you had injections at L1, L2, L3, but really only L3 is what gave you relief. The rest didn't do anything. So in a way, they can also be diagnostic, which is helpful to us as surgeons to create surgical plans where we keep things as minimal as possible, but still addressing the problem that is causing the issue. So they're really a fundamental part of what we do as surgeons, not that we do them ourselves, but they're a fundamental part in how we treat patients and diagnose patients for spinal conditions.
Okay, thank you. Yeah, interesting to hear how fundamental it is. As a follow-up to that, Dr. Gopez, I'll turn to you. What are these next steps then when therapy and back injections might stop working?
Sure. So, well, the good news is that 80% of the time, conservative treatment's going to work. So what that means is that the vast majority of patients don't go on to need either neck or low back surgery. But unfortunately, as Dr. Hadsiba had mentioned earlier, sometimes the pain gets to the point where it's affecting your quality of life, affecting your ability to make a living. And if it's doing that, then I think you have to consider surgery. I think we'll start with the lumbar spine. So in the lumbar spine, if you have a herniated disc that's compressing the nerve and you have radiculopathy, the surgery for that works very well, roughly 80% success rate. It's an outpatient procedure. The incision's usually under 1.5 inches. Some guys actually do it endoscopically, and those incisions are even smaller. In our institution, it does require general anesthesia, but the procedure's an hour or less. You go home that day. Everything's closed with absorbable sutures, so you're showering 24 to 48 hours later. I let my patients drive a week after surgery, and depending on what type of work they do, I might let them go back to work as soon as 2 weeks after surgery. But generally, it's 4 to 6 weeks after surgery that I clear them to go back to work. The neck's a little bit different. Well, actually, it's very different. So in the neck, when someone has a symptomatic herniated disc in the neck, we actually have a couple of options. In my hands, I tend to tackle these discs through an anterior approach, meaning going through the front of the neck. But there are some surgeons who will treat these equally as well by going through the back of the neck. In terms of going through the front of the neck, unfortunately, you have to go through the disc from front to back to get to where the problem is, which is typically the back of the disc. And so you're sort of left, when you take out the whole disc, you're sort of left with a gap between the bones that you have to fill with something. And so traditionally, we've done fusions for these herniated discs, where we take out the whole disc, we pack bone into the disc space, we put a kind of structural cage or a piece of bone, and then it's fixated to the bone above and below. And over the years, we've noticed that those patients tended to have an increased risk of developing problems either above the level that was fused or the level below the level that was fused. And roughly 30% of those patients ended up needing surgery within the next 5 years downstream. So more recently, and by that I mean over the last maybe 5, 6, 7 years, the other option that we have available to us now is to do artificial discs. So instead of doing the fusion where we lock the bones together, we're putting an implant that articulates and that preserves the motion at the operated level. And by doing that, not only does it preserve motion in the spine, but it has also shown to reduce the incidence of needing future surgery at the adjacent levels. But the bottom line is, most patients with a herniated disc will not go on to need surgery. The ones that do have to do it for the right reasons. Either it's affecting quality of life or affecting their ability to work. One thing I just want to piggyback off of Dr. Siva about the fusion. Well, in the lumbar spine, and that's what I'm going to focus on here, when you have a herniated disc in the lumbar spine, you don't get fused. That operation is designed just to remove a small portion of the disc, the portion that's irritating the nerve, and then that's it. The only instance where you might need a fusion is in the case of recurrent disc herniation. So if you have a herniated disc in the lumbar spine and you have it removed and you do well for a period of time and then it re-herniates, the option at that point is to do another discectomy, or you can do a discectomy and fusion. I will typically reserve the fusion for the third operation, not the second operation, because when you do the fusion, then you're taking out the disc in its entirety, so it doesn't have any ability to re-herniate. But by doing so, you're again locking two bones together, and that could potentially invite other problems downstream at the adjacent levels. But by and large, in the upfront herniated disc patient that goes on to have surgery, there's no fusion done.
Okay. Thank you so much. All right. Continuing on this conversation of looking at more of the surgical options, Dr. Holscher, do you mind just describing a little bit more about what spine and back conditions that surgery can correct?
I would just I would be careful with the term correct. I think that's an important segue into like the most important part of spine surgery. I feel like, or really any surgery. It's not just spine. It's anytime you're doing anything invasive, in the operating room. It's making sure that patient and provider expectations align and meet. And I think sometimes patients come into the consultation with that mentality of what can I correct here? Surgery is not a correction. Like a surgery is often addressing progressive degenerative arthritic conditions in the spine that are leading to oftentimes nerve compression that are causing pain and or weakness and interfering with quality of life. But surgery is not an eraser, and a whiteout and making everything normal again. There's a consequence to every surgery that you do, and that's been touched upon now, I think, in a couple of questions here. These notions of adjacent level disease or recurrent disc herniations. The spine is a really complicated biomechanical machine, from skull down through neck, thoracic spine, lumbar spine, into the sacroiliac joints, into the wings of your pelvis, into your hips and into your knees. It's all connected, and there is no, there's no, I often tell people there's no free lunch. Like there is a consequence to everything that you do or that you don't do in the spine. And so there is no spine transplant. There is no, there's no turning back the hands of time, so to speak. So we reserve surgery for, when do patients have a problem in the spine that is causing, usually the problem we're addressing is nerve, either peripheral nerve or spinal cord compression. And is it clearly concordant with the symptoms that they have? And are there any other variables that are muddying the water or that may mimic a spine problem for which, that you've eliminated or need to eliminate, right? And so in general, for me, if I can take a patient and what they're describing to me, the symptoms that they have, if it makes sense and is concordant, meaning it aligns, it makes sense with what I see the problem to be on MRI, and ideally they have failed some attempted conservative management, well, then I would say that patient is a good surgical candidate, right? Like I wouldn't use the term will get corrected by surgery. I would say that patient is a good candidate and is more likely than the average to have a good outcome with surgery. And that's what we want. Like for my end, I don't want to just offer surgery to patients, for the sake of offering surgery. I want to be able to honestly tell somebody, listen, you're a good candidate. I cannot crystal ball and tell you, yes, you will be pain-free. Most patients that you can feel good about offering surgery to are going to do well with surgery, right? So of course, assuming that you've avoided some pitfalls and complications of surgery. But in general, if things go according to plan, they often do, then generally patients will feel better. It doesn't mean they will be pain-free. It doesn't mean that they won't have other degenerative levels in their spine. It doesn't mean that down the road, they won't develop, for example, adjacent level disease or need another surgery down the future. So the way I would answer this question is there are many different problems that surgery can, there are many different problems for which patients are sometimes good candidates for surgery and are more likely to do better with. But for me, it has to be a patient who is in reasonably good health, who has made a good effort at conservative management, if that's appropriate, who has pretty focused complaint or focused symptoms that are concordant with what I see on the imaging studies that I've ordered, right? And if I can't say that, well, then either the patient is not a good surgical candidate, right? Is just generally unhealthy or is unlikely to do well. The risks maybe outweigh the benefits of invasive surgical procedures, or their symptoms are all over the place and are not really localizable to what I see in the scans. And a little bit more diagnostics are in order, whether that's, again, targeted injections or getting help from consultants like orthopedics and neurology and pain management and rehab doctors and EMGs and stuff like that. Or we've done all that and we can't really localize it. And at that point, you get into kind of the muddier water of, well, here's what we could do. It may or may not help. I would tell you honestly, maybe you're not as good of a candidate as the average patient, but if you've exhausted other options and your quality of life is really suffering, surgery may offer you benefit here, right? And so that's oftentimes how I view patients' surgical candidacy. And I try to avoid that term of fixing things. I think patients often have that picture of, we're going to fix this and my spine is going to be, you're not going to have a 20-year-old spine again if we do whatever operation it is we're planning. It's just, we're trying to maximize your quality of life. And sometimes surgery is helpful for that.
Okay, thank you so much. And thanks for clarifying that as well. I see a lot of great live questions coming into the chat here. So I think we'll just take one or two more questions and then go ahead to our live Q&A. So Dr. Siva, we'll turn to you along the lines of what Dr. Holscher just discussed. I guess, do you mind just kind of describing how someone should know when it's time to potentially pursue back surgery?
Yeah, echoing sort of what my colleagues here have said, if you've made a really good effort at some of these conservative therapies, whether it's the yoga and the Pilates or the injections, traditional physical therapy, certain types of pain medications, and it's just affecting your quality of life, and you feel like you can't keep going on like this, and you're thinking to yourself, is this my new normal now? And if that's no good, and you're not able to spend time with your grandkids or your children or do the kind of work you want to do, if you're not feeling like yourself anymore and you feel like you've hit a wall, then I think surgery can be helpful in the right situations. And as I mentioned before, I enjoy doing like minimally invasive and endoscopic spine surgery. And part of the reason for that is that because these types of procedures are less of an ordeal, they require less of the patient. You can get back to work faster, be out of pain faster, get home faster, drive faster. I think in some situations, those kind of procedures can be a good idea earlier on. Because if I were a patient and I had the choice between sort of a bigger operation that's going to take more out of me, more out of my family, I might push it off a little longer. And really make sure I'm desperate and I have no other options in sight. But if I have an option of something that with a really small incision where I go home the same day and I'm back at work a couple of days later, driving a couple of days later, I might consider that earlier on when I'm not so much backed up against a wall, metaphorically. So that's one reason why I enjoy doing some of these minimally invasive and endoscopic procedures. In some ways, they represent this middle ground where you have things like injections over here on the left, and then you have traditional surgery on the right. And there's this sort of gray zone in the middle with these endoscopic procedures where oftentimes we're using a needle to go in, not too different from the steroid injections. And then we're putting a very small tube down through that needle and then putting a camera down there and doing a small cleanup procedure. So there's this new sort of space that's occupied in between injections and traditional spine surgery. That is one thing that I enjoy doing that I think can be an option for patients a little bit earlier on than they might be otherwise with traditional surgery. But I hope that helps.
Absolutely. Thank you so much. Okay, we'll take our last question here and then go into our live Q&A. So the last question, Dr. Stefanelli, we'll turn to you. Can you talk just a little bit about the new research for back and spine treatments? Are there new and updated surgical and non-surgical options? I think our audience members will certainly be excited to hear.
Sure. Yeah, that's a great question. I think Dr. Siva was alluding to this as well. It's interesting, like spine surgery, even 10, 15 years ago is much different now than it was back then. And I'm sure certainly in the next 20 years, it'll be vastly different than it is now. As time progresses, we've gotten a lot smarter with spine surgery. And as such, we've gotten a lot smarter with the workup of spine conditions and treatment. So, we could start it just from workup, right? There's new types of imaging studies that we're doing now that were not in existence or not traditionally used, certainly in this country or in the recent past. There's different nuclear medicine studies that we're getting on patients now. One of them is called a SPECT-CT. It's a nuclear medicine study that actually looks for arthritis. Again, people that have these spines that look like terrible. Every level is degenerative and there's arthritis at every single level. How do you isolate what's the problem? So we have new imaging modalities available, whether they're new in general or they're new to spine workup. So that's one thing. So the workup of these problems, there's a lot of new innovation with that. When it comes to procedures, both in the pain management space and then also in our world, there's a lot of new procedures that exist now that weren't around 5 or 10 years ago. So as Dr. Siva said, minimally invasive techniques that we're using, we all do some form of minimally invasive, some of us more than others, but spine surgeons in general, I mean. But 20 years ago, people weren't doing these surgeries through a tube or with a camera. And now we're able to take these, what were historically big surgeries, and turn them into, like Dr. Siva said, a much smaller ordeal for patients. So it's a kind of a broad question, but in every step of the way, both in the workup of spine problems and the workup of chronic pain, and then the other thing to talk about, and not that it's a brand new therapy, but something that has become more popular, certainly in the last 10 years, for patients that do not have a surgical spinal disorder. Now, that is not to downplay that they don't have back pain or nerve pain or things like that, but not all of these conditions, unfortunately, can be solved with a scalpel or with screws and rods, right? That's oftentimes not the right answer. There's pioneers in the world of what's called functional neurosurgery, or neurosurgery to help patients' quality of life, something called a spinal cord stimulator. And these have been around for a while. It's not a new therapy, but the technology surrounding spinal cord stimulation, which is essentially, you could think of it like a pacemaker. People think of a pacemaker for their heart. Spinal cord stimulator is essentially a pacemaker for your spinal cord. And we don't exactly know 100% how it works, but the general concept around it is that it sort of scrambles the pain signals that are traveling up to the brain, right? Because pain is purely in how the brain interprets signals that it's getting from the body, right? Spinal cord stimulation can be effective for some people, not everybody, but for a lot of people that have problems that are not overtly surgical, to get them a lot of relief and life-changing for many people. So, really what it comes down to is in the technological space, there's a lot of advancements that have been made in the last 5 or 10 years. In the surgeries that we do, things are a lot minimally invasive now that they historically would require a big open surgery. Now we can oftentimes throw a camera down and do something very small, as Dr. Siva said. And then even in the workup of people with historically very complex problems, we have different imaging modalities and different studies that we can now order that were not available to us 10 years ago that can really revolutionize how we treat patients, surgically and non-surgically.
All right. Well, thank you so much. And again, just exciting to hear these advances. So we appreciate it. All right, we will turn to our live questions now. So excited to kick those off. I will open with our first question, and whoever wants to chime in, feel free. So the first question for tonight from the audience, at what point would you advise seeing a specialist like a neurosurgeon? In other words, is it worthwhile to see a specialist in the early stages of treatment, such as PT prescribed by a PCP, or better to wait until the problem becomes more serious? And whoever wants to take that question, feel free.
I don't think there's anything, it's always reasonable and a good idea to go, like if your back and legs hurt or your neck and arms hurt, it's never a bad thing to be in early to see a surgeon. Now, oftentimes, so I see, for example, I don't know how everyone else's practice is. Like I see a lot of people all over the gamut. Like I get people teed up from pain management who have done therapy, who have done chiropractor, who have done injections, they've had their MRI, like they've got everything and they're just ready to sign up, right? That's obviously, listen, from a surgeon's perspective, that's obviously wonderful, right? But I see a lot of people that are like referred directly from the ER or directly from the primary care doctor who have never done physical therapy, who have never seen a pain management doctor, who have never had an injection. And sometimes, patients are not getting directed efficiently in the right directions, right? And so there's nothing wrong with seeing a surgeon early. It just, I wouldn't be, if you haven't done any of that stuff, I wouldn't be surprised, if a surgeon is not offering surgery right away. We still, if you're seeing me kind of ahead of schedule, then I should still shuttle you through some of the non-operative things that you haven't done in the past. But no, there's nothing wrong with seeing. I see plenty of people in my clinic all the time that literally have done nothing, have had, a couple months of pain and haven't been through even a lick of physical therapy or anything yet. And I have no problem quarterbacking that. If anything, it's probably a little bit of a more efficient means of making sure people are getting through the right pathways. And oftentimes there are some insurance barriers to getting advanced imaging. So oftentimes, primary care doctors are having trouble getting MRIs authorized, for example. And So it's not a bad idea sometimes just to have some documentation in the surgeon's office and making sure that you've done the appropriate physical therapy, you've been referred to pain management and all those things, so that we can, not have this be a lingering issue for years and years before you finally see someone.
Okay, thank you so much. All right, next question. And again, for whoever wants to take it, are there specific treatments to reverse or help with neck kyphosis?
I would just say, reversing kyphosis, a kyphotic deformity in your neck, meaning, so kyphosis, just for the kind of all the listeners out there, just means your neck normally has a kind of a reverse posture, meaning that you have your neck kind of, usually if you look at images of the spine, kind of curves backwards a little bit. And kyphosis means that your neck is kind of stooped forward a little bit. And that's often related to really advanced degenerative disease. So the discs have often collapsed, the facet joints have become a little bit lax. And on top of that, you have kind of weak paraspinal core muscles that are not supporting those levels, and your neck kind of stoops forward. Yeah, I don't think there's any exercise that will necessarily reverse your kyphotic deformity in your neck. And a kyphotic deformity in your neck, just to be clear, doesn't necessarily have to be reversed, right? Just because your neck is straight or not lordotic doesn't mean that it has to be fixed surgically, but it is evidence, I think, of broader degenerative disease and arthritis. And I think it just kind of goes back to the importance of core paraspinal muscle, postural muscle strengthening to support and try to limit the degree to which those discs want to degenerate. They want to lose their height, and the facet joints want to become a bit lax, and your neck kind of wants to fall forward. So I would say it's PT and core, it's core paraspinal muscle strengthening. But again, if you're not, just because you have a kyphotic neck doesn't mean you need surgery.
Okay, thank you. Strengthen that core. All right. Dr. Stefanelli, we will turn to you for this next question because I know you had mentioned it previously, but what is the best treatment for cervical radiculopathy?
Right. So cervical radiculopathy, meaning what we could think of again as sciatica of the arms, more or less. The same sort of electrical shooting type pain, can be numbness and tingling type pain. It can manifest in a few different ways, but it generally tends to come in different patterns, depending on which nerve is affected, going from the neck down into the shoulder or the back of the spine, into the arm, and different portions of the arm, depending on, again, which nerve is being affected. In the absence of cord compression, of spinal cord compression, meaning that the nerve is compressed, but the spinal cord is fine, we recommend the same things that we would generally even in the low back. So non-operative stuff. So time, right? So 6 to 8 weeks of non-operative therapies. And most people, 80 to 90% of people will heal with the tincture of time. But in the interim, while that time is progressing, epidural injections, some pain doctors feel comfortable doing even targeted nerve injections in the neck, which is safe in the right hands. Physical therapy, PT, all of the things that we talked about for non-operative stuff, if you will, are the same mainstay treatments that we use in the neck or the low back. But again, the neck, the difference becomes if there has to be an absence of cord compression. If there's cord compression, that's a different story. And we generally treat that with surgery as a first line if there is symptomatic cord compression. But generally speaking, very few people go on to, now we do a lot of them just by nature of it's a common problem, but very few people go on to require surgery for radiculopathy or sciatica. Because it heals on its own in most folks. When you've exhausted those therapies or when the pain becomes too much over time, we start talking about surgery. And Dr. Gopez touched on that a little bit. Generally, surgeries are done from the front, not always, though we can do them from the back, and that gets a little, it depends on the surgeon and the type of pathology involved. But there are ways to treat it surgically, obviously, open and minimally invasive as well.
Okay, thank you so much. All right, next question. We have a lot of them, so thank you all. These are great questions. Is there any way I can get relief from spinal stenosis? Will losing weight help? And whoever wants to jump in here, feel free.
Yeah, I'm happy to jump in on that one. I think weight loss can really be helpful. In a very sort of simplistic terms, when the spine is bearing extra weight, that means more load, more forces at play that can accelerate the degenerative arthritic process that's already happening. So if you're able to lose weight, that can oftentimes, even in and of itself, improve your mobility, improve your pain, and make it so that you don't necessarily need surgery. Perhaps more importantly, sometimes patients have significant spinal problems and they've tried everything else and they're considering surgery. The same surgery done in someone who is overweight or obese can have a higher risk profile than that same surgery done on a patient that's not overweight or obese, whether it's from a wound infection risk or just the technical difficulties of performing the operation, the time of the operation, so on and so forth. So for that reason, if you sort of know that surgery is in the cards, if you're able to lose weight, that can make that same surgery have a higher probability of success. But having said all that, I see patients oftentimes where it's a catch-22. It's not really always fair to tell a patient, hey, if you're able to lose some weight, then your pain might be better, or you might be a better candidate for surgery, because oftentimes the pain is stopping you from being mobile. And if that's the case, you're trying your best. It may be really hard to get more active or to take more steps every day when the very spinal problem that is putting you in this position is preventing you from being more active and losing weight. So that's a trap that many patients find themselves in. And so it's easy for doctors to say, hey, if you could lose some weight, maybe you can make it better, or then I'll do surgery on you. But that's easier said than done. Patients are often the ones that are dealing with this day to day. And that if you've got horrible back pain or crippling leg pain and it's stopping you from being able to stand for long periods of time or walk or even leave the house, how can you be expected to be very physically active and then shed some of those pounds? So one thing I will say is that, very frequently I will send patients to the weight management sort of team at Jefferson. It's a wonderful service that Jefferson provides. It's unique in the tri-state area, where it's essentially a multidisciplinary team of doctors that are laser focused on all the different aspects of weight management, whether it's diet, lifestyle, mental health, everything together. I don't think I've ever had a patient that I've sent to them that has come back and said, hey, that was a waste of time. I didn't really like what they had to say. And so I think that sort of approach can be helpful, because it's not always diet. It's not always physical activity. It can be a combination of those things and other things as well. So weight loss can be a critical piece of the puzzle, and getting help from the right sorts of people can also make a difference.
Okay, thank you so much. All right, moving along to our next question. This is from one of the audience members. I have damage from L5 nerve root, which has caused foot drop within the past year. Would surgery help for this? So more of a specific case here, but if anyone wants to comment on it, feel free.
I'll take a crack at this, if that's all right. So the problem is that you don't know how badly damaged is the nerve and whether or not it's recoverable. I remember going through training, and one of my attendings taught me that if it's a painless foot drop, the chances of that nerve recovering from surgery is significantly low. And the fact that it is painless is an indicator that perhaps the nerve has died. On the other hand, if you have foot drop and pain together, that scenario is much more favorable towards surgery. And in those patients, I would favor early surgical intervention, especially in the setting of a foot drop with pain. I don't know if the other surgeons have any other experience with it, but by and large, if it's painless, I'm less inclined to suggest surgery for that.
Okay. And if anyone has any other comments, feel free to jump in. Otherwise, we can continue. But thank you so much, Dr. Gopez. All right, we'll go ahead to the next question. How do you differentiate orthopedic issues from rheumatoid issues when you have a high rheumatoid factor, but no real pain? This person says they're just unable to walk upright with some disc herniation. And Dr. Holscher, I believe you're on mute right now.
Can we repeat the first part of that again?
Yeah, absolutely. Okay, so how do you differentiate orthopedic issues from rheumatoid issues when you have a high rheumatoid factor, but no real pain? And again, this person just says they're unable to walk upright with some disc herniation.
And so what is the reason for, do we know anything? I mean, it's just hard to say, like, unable to walk upright with no pain. We need to know a little bit more about, why you can't walk upright. Rheumatoid arthritis, of course, is a diffuse inflammatory condition, right? And so, and rheumatoid levels, factor being high in the blood is a very non-specific finding too, but can impact all your joints, including diffusely in your spine. And how I think it's worth mentioning that patients will often read their MRI reports, and MRI reports can sound, sometimes, not all the time, but sometimes they sound much worse than they really are. So oftentimes patients will come into our clinic and be like, oh, every one of my discs is out, right? And you read the report, and sure, if you read the report, L1, 2, L2, 3, L3, 4, L4, 5, every single level, the radiologists are professional. Like, they were going to dictate every little finding, right? If you don't have a 12-year-old lumbar spine, like, there's going to be stuff at every level, right? But a little bit of a disc bulge, is normal for most patients, right? If I MRI'd myself, I guarantee you every one of my lumbar discs is going to bulge a little bit. It's going to be a little bit dark. There's going to be a little bit of joint overgrowth or ligament thickening. Doesn't mean that it's symptomatic or pathologic or needs, treatment. So I'd say it's a little bit hard to interpret that question because, it's unclear why you have pain or why you can't stand up straight, and especially if it's painless. We'd have to know a little bit more about what's going on there.
Well, thank you so much. An important consideration to keep in mind, as you mentioned, if someone's going ahead and looking at those results. So thank you.
If I could chime in, Sarah, real quick, just something Dr. Holscher said that I think is really beneficial for patients to hear towards the end there. I always encourage patients to be very careful about interpreting or reading their own radiological reports by the radiologist, and not that they shouldn't understand them and read them, but what oftentimes ends up happening, and it creates this false sense of fear, and because, when a radiologist reads an MRI report, they have to read everything that is abnormal. And even if that abnormality is clinically insignificant, their job is to read it. So, I'm sure we all see patients in clinic that panic and make an appointment with a neurosurgeon because they have some minimal neck pain. They get an MRI by their PCP and it says, mild disc bulge at C3-4, mild disc bulge at C4-5, disc herniation at C6-7, L3, 4, et cetera, et cetera. So people think that, anybody in their late 20s and on is going to have some degree of arthritis in their spine. And that's totally normal. Unfortunately, the way we're built is that we put a lot of force on our neck and our low back, and it's not unusual. Like I said, even people in their late 20s, all the way through the elder years, can have that. So I just think, some Christian said it, that it's important to know that just because you see something on an MRI scan or a lab value or something, it's oftentimes a good idea to speak with, a professional, either your PCP or a neurosurgeon, whoever it may be, because oftentimes an isolated thing, an isolated abnormality is not usually a huge deal. Certainly on an MRI read and this and that, but it's good to have an understanding of that. A radiologist is going to read things in a way that is going to sound scary, but oftentimes it's not a big deal at all.
Okay, well, thank you so much. All right, we will do one last question from the audience and then wrap up for the evening. Dr. Sybil, we'll close it out with you. And, we not sure if you can provide an exact percentage here, but this person is curious to know what percentage of persons who have minimally invasive spine surgery end up needing to have invasive surgery.
Yeah, that's a great question. I've had family members who've asked questions like this because you sort of intuitively think that, okay, if I'm paying less for something metaphorically with a smaller procedure, am I going to have to pay more later because maybe, it wasn't as effective or something like that? So we always, those of us who do this sort of minimally invasive spine surgery always make a joke that minimally invasive cannot mean minimally effective, that you still need to be accomplishing the same goals of surgery as traditional surgery, whether that be sufficiently creating space around a nerve or having to do a fusion in certain situations. So I would say that in the right hands, which means someone who is doing these types of procedures often, I don't really see a higher rate of reoperations after minimally invasive procedures as compared to traditional surgery, as long as you're trying to address the key issues that are disabling a patient, and you're doing it in a thorough way. And especially with advances in the techniques, it used to be 10, 15 years ago that because the incisions were smaller, the surgeon couldn't see as much. And in those early days, there may have been situations where the surgeon wasn't able to clean out all the areas where the nerve was under pressure. But now with advanced cameras, with something called image guidance, which is like a GPS system that we use, we can actually see more than ever before through almost a keyhole approach to the spine. We're really making a targeted strike just to the area where there's an offending problem and minimizing the collateral damage.
All right. Well, thank you so much. And thank you everyone for submitting such thought-provoking questions. We really appreciate it. I know I have one last question myself, and then we will wrap up. But for the final question this evening, I would like to ask all of you, what are your goals for everyone listening in on this webinar? What do you want our viewers to take away from tonight? Dr. Holscher, we'll go ahead and start with you.
If I could just reiterate maybe one thing I said earlier, it's the importance of matching patient and provider expectations and understanding that surgery is not a fix. It is not an eraser. It's not a, you can't just rewrite, the history of your spine. Surgery, in a well-done surgery for the wrong reasons is a bad surgery, right? For example, lumbar fusion where the screws look perfect on the x-ray, if it was done for bad indications, a bad surgery. For the right reasons is a good surgery, right? And so matching patients, in good health, who have attempted conservative management, who have concordant symptoms and MRI findings, and those are generally good candidates for surgery and good and likely to do well with surgery. But understanding that there are limitations to surgery too, and it is not a magic bullet for everything that is going on. There are consequences downstream to having surgery, right? To the biomechanics of your spine. Like all of that is important to understand, and making sure that patient expectations are reasonable. Pain-free is not a reasonable expectation, right? Better pain, better quality of life, doing things I couldn't do before is a reasonable expectation. And that's generally the conversation I'm having with patients before we commit to surgery. And then I just say, and somebody had, I think one of the audience members had asked, it's just the importance of getting in and having a discussion early it's never a bad thing, right? So just because you haven't, you're unsure if it's time yet to see a surgeon, then go see a surgeon, right? And if it's not time, I'll tell you, and I'll make sure you're doing the things you should be doing before we get to serious surgical discussions.
Okay, absolutely. Thank you. All right, Dr. Siva, we will turn to you. Any final takeaways for this evening?
Yeah, I think this notion that, if you're being recommended a spinal fusion, to at least seek a second opinion, I would reiterate that point. There's a lot of new philosophies that are coming out. For example, Jefferson is now part of a clinical trial on a lumbar total joint replacement that we are participating in. So in the same way that hips and knees used to get fused and now you get those joints replaced, we're now one of the leading sites in the country in that clinical trial. And we also offer cervical disc replacements that in certain situations can be an alternative to a spinal fusion in the neck. And so as Dr. Holscher mentioned, the spinal biomechanics are very delicate. You do a fusion in one part of the spine, it can have a domino effect elsewhere. So if you've been told at a spinal fusion that you need one, you may very well need one, but I definitely recommend getting a second opinion with one of us to make sure that's in fact the case.
Okay, thank you. And Dr. Stefanelli? Any final takeaways?
Sure. Yeah, I think, kind of everybody's sort of echoing the same things, but I think it's very important that patients in general have a good, solid understanding of what their expectations may be, meaning that a lot of people will see in clinic think that surgery, and we see both sides of the spectrum. People come into clinic thinking that like, I need surgery. This is the thing that's going to fix me. And oftentimes, and I tell the same thing, we all tell our patients this, if you have a surgeon telling you that you should not have surgery, you probably should not have surgery. Again, the other importance of seeking second opinions, I think, is no good surgeon or reputable surgeon will ever get offended by you seeking another opinion. Never. If they don't want you to seek another opinion, that's a red flag. If any patient ever asks me or any of the four of us, certainly, hey, I'm having some concerns about this. I tell patients, you should feel this is your body and you should feel the most comfortable with what is being done to it or not being done to it. So I think that's important, but also that patients should understand that there are two sides to the coin. Surgery is not always a fix for everything, even though we would love it to be. But the other side to that is we oftentimes see patients who are debilitated by very simple problems that can be very easily fixed with simple surgeries. That are so adamant against having surgery that they would rather be debilitated every day, So I would just say keep an open mind in either direction. Seek out the guidance from multiple providers, and generally try to do what you think is going to be the best for you, whether it be conservative management, surgery, et cetera. So just really setting good expectations for yourself and what you're expecting to achieve.
Great. Thank you so much. Okay, and finally, Dr. Gopez, any final remarks before we close out this evening?
Sure. So I can't agree more with what the other docs have already said. Obviously, surgery, spine surgery isn't for everyone, and it certainly has limitations on what can be accomplished with surgery. Probably the biggest thing I want to express is that the patients that are likely to do best with spine surgery are the ones that complain more of extremity pain, meaning more arm pain or more leg pain and less of the neck pain or the back pain. So surgery, the outcomes from surgery are more predictable in terms of what it will do to improve what's going down your arms or what's going down your legs. But it's less predictable in alleviating primary neck pain or primary back pain. And I think sometimes the patients have a hard time understanding that. When we do these surgeries, we're decompressing nerves. And for the most part, these nerves, they go down the leg or they go down the arm. And that's why when we do these surgeries, the symptoms in the arms or the legs generally get better. But if you're looking to have surgery because back pain's your only symptom or neck pain's your only symptom, those surgeries have a high failure rate.
Okay, thank you. An important last call out to keep in mind. So we appreciate it. Thank you all. Thank you, Dr. Holscher, Dr. Siva, Dr. Stefanelli, and Dr. Gopez, all for your time this evening. Certainly a lot of great information was shared about back and neck pain and spine health. And thank you all again for attending and submitting your wonderful questions. We will be posting an event survey so you can let us know your thoughts. Was this helpful? Are there any other specialties you would like to hear from? Your feedback will help us bring more virtual events like this to you, the patients. And if you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. And be sure to visit jeffersonhealth.org to stay up to date on upcoming classes, events, and webinars just like this one. A recording of this event will also be sent to you so you can rewatch at your convenience. And if you would like to view other Wellness Webinar Series events, please visit our Jefferson Health YouTube channel. We have everything from back and neck pain to robotic surgery to planning for pregnancy and much more. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening.